Thank you, David, for this honor to come over and speak about the future. So I don't have much to say because I don't see the future that clear. I know that we are going to have a lot of challenges in regards to this new tool that we are going to face in the context of all this new technology that we have available right now. So in regards to artificial intelligence in pathology, especially the prostate cancer, there is a lot of hope. We have promises in diagnosis, prognosis, treatment, etc. And then these kind of machine learning algorithms are basically developed with a very large amount of data that now we are able to get access to, and we can create as much as well as in order to be able to play with them. And I say play with them because there is a lot of issues that we need to consider in regards to how we are going to interpret these results that we can expect in regards to our patients. The hope is that we are going to improve accuracy, faster diagnosis, almost integrate all the digital pathology we have at hand at this moment. We have personalized approaches that we can give to the patients, combinations of different imaging modalities like X-rays and pathology, and also tremendous advances in research, and then several challenges and ethical considerations that are going to come and question the system, and question the data, and question the results. So why do we use, or do we want to use artificial intelligence in diagnosing prostate pathology? It's quite a we think that it's going to provide all this new vision of pathology that is still a mystery in our hands. I'm a pathologist. My patients don't talk to me. I try to talk to them, but in contrast to what you practice, I think that they talk to me with images. And then all this interpretation of histology, appearances, etc., in correlation with the clinical background is what is going to give us all these tools provided by this magic technology that we have now. This is just a summary of all the technological advances that have allowed, in general, the development of artificial intelligence, starting with the supercomputers, and not only that, but the network of computers all over the world. Now we can connect all these different databases with the cloud, with the different kinds of hardwares that are able to integrate this data, and also libraries, etc., that we need to construct, we need to create in the cases specifically for prostate pathology. So some of the technological jargon that is being used in all this process of developing artificial intelligence, I had to learn them a while ago because I didn't understand them. So ground truth. The ground truth is basically the reality we want to model. And then we need to establish specific targets to validate models that we are going to label in specific ways. And then all these database, classification, etc., is going to be translated into kind of a language that needs to be interpreted by these machines. But it's at the end the responsibility of humans, the ones to have to define the objectives of this ground truth. And if we fail to provide that kind of interpretation of that data, is when we are going to see either a success or a failure in our system. For example, compare Gleason 3 versus Gleason 4 as was established by Gleason in 1966 to the present interpretation we have Gleason 3 or 4. If we had to create an artificial intelligence based on the knowledge that Gleason had in 1966, and we want to apply it now, we were going to be making a lot of mistakes. And the same is going to be now when we try to establish specific systems with the knowledge we have right now. And then the fast pace that this technology is going to have in the development of new knowledge is going to push us to develop new algorithms and new ways to interpret pathology images in comparison with the clinical outcome of our patients. So this data leakage is one of the things that everybody's scared of, because if we enter data that is going to be biased by a particular number of programmers versus another school that interprets the data in a completely different way, we are going to be fooling ourselves, because that data, even though it's going to perform very well, is going to give us false language or some false results. So we have all this labeling of the data, softwares that are going to be used to label this data that we are going to feed these machines, and there's different commercial images, and et cetera, et cetera. And probably the best development of image technology trying to identify images is in the face recognition. And face recognition now, even probably the original way to identify people was with fingerprints. That was before artificial intelligence. And we were able to select these individuals to be able to identify one particular individual. So with all this database, we can create really interesting things. For example, can you identify these people? So they're very famous. This is what is called fake faces. These people don't exist. They were created with artificial intelligence based on the face of thousands of people, and then based on the programmer, they try to put glasses, or is a male or a female, et cetera, et cetera. Another development is the try to identify, for example, faces from blurry images that probably in cameras, in public places, they try to find criminals or things like that. But this is a work done by Duke University, and it shows the limitations of this. Because here, trying to identify the face of this girl from all these pixelated image, very blurry image, sometimes the crystal clear image of a real person may be what could be possibly in real life, but it's still giving us some idea of what we are trying to look for. This is another case of one of these work done by Duke University. And here we go with pathology. All these four examples are Gleason 4. Now, how can in hell we say that which patient is doing better than the other, having these overt differences in the morphology of the cancers? So I envision that in the future, we are going to have very large database, not only from our country, but all over the world, where we are going to find, for example, individuals with this kind of pattern that is still kind of form clusters, but they have this kind of signaling cells versus this other Gleason 4 that it has a more glandular differentiation, this kind of a mucinous differentiation, this kind of a more overt differentiation. Even I didn't put the case of the cribriform appearance, etc. But I can assume that all cancers are not created equal, and all people are the same way, as we know. So the turnout or the prognosis of these patients, probably in the future, our Gleasonic grading, our gray group grading is going to change dramatically in base of this reality. These are just some comparison of the clinical work that is normally happens in our practices as compared with the future, how these images, either radiological or histological, can be programmed to even make the definitions between aggressive cancer and indolent cancer, and both in X-rays, ultrasounds, and pathology images. And this is another algorithm. As you can see, the ground truth is the one that is going to be decisive for the programming and interpretation of these lesions in the future. This is another close-up for the way that pathologists have outlined a specific lesion, and then with some work by Dan about a couple of years ago by his group, they were able to correlate the images done or identified by artificial intelligence. At this moment, we have laboratories that are pretty big, with people just concentrated in the study of this data. And in summary, what we're going to say is that this is one of the futures in prostate cancer diagnosis at the pathology level. We are going to reduce, not eliminate, but we are going to reduce most likely the interpathology variabilities. We are going to have better points to streamline diagnosis, evolve into the grading, most likely, as I mentioned before, predict outcomes in a more precise way, and also with many challenges that we still don't know what they are going to be present at this moment. These are some of the references in the last 2 years. Thank you so much.